Okay, so I'm going to call to order the regular meeting of the Watsonville Community Hospital Board of Directors for Wednesday, April 29th. Rosie, whenever you can, please give us a roll call.
Yes. Dr. Bowden? Here. Dr. Friel? Here. Dr. Gallagher?
Here.
Dr. Pimentel?
Here.
And Tony?
Here. We have nothing to report out of tonight's closed session, so I'll move us on to any agenda modifications for consideration from staff. Anything from staff? Okay, seeing none, I'll move us on to the public comment on matters not on tonight's agenda. Is there anyone, I'll go online first. Is there anyone online wishing to speak on an item not on tonight's Watsonville Community Hospital board member board of directors meeting? Anyone online? Okay, seeing no hands raised, I'll go out to the public here. Anyone wish to speak on items not on tonight's agenda? Okay, seeing none, now close down the public comment and open up for any comments from our board members before we get into our consent calendar. Comments? Okay, I'll move us on then to our consent calendar. We have two items on consent. The first one is our minutes approval for our March 25th, 2026 meeting. And the second is our policies summary approval for April 2026. Do we have any questions from the board before I go out to public comment on these two items? Questions? Okay. Seeing none, I will go out to public comment for our consent calendar. Anyone online wishing to speak on either one of these two items? Okay, seeing none, anyone in person? Okay, I'll close down the public comment and I'll bring it back to the board for an appropriate motion and further discussion.
Move approval of consent, just with the comment of appreciation for the policy we have on responding to immigration law enforcement.
I'll second. Thank you, Directors Pimentel and Friel. I'll take roll on this item. Director Bowden? Yes. Director Friel? Yes. Director Gallagher?
Yes.
Director Pimentel?
Yes.
And Tony?
Yes. Okay, I'll now move us on to our first discussion item of the night. This is the Medical Executive Committee's report of approval for April 2026. This is an item that we received for reporting closed session. Does the board have any questions about item number 3 before I open it up to public comment? Okay, seeing none, I will go up to public comment on item number 3. I'll start online. Anyone online wishing to speak on item number 3?
No hands.
Okay, anyone in person wishing to speak on item number 3? Okay, seeing none, I'll close that down and close down the public comment and entertain an appropriate motion for item number 3 from the board. Move approval. Thank you. You get a second.
Sorry, what was the second, Bowden?
Director Ball.
I'll take roll on that item. Director Bowden? Yes. Director Friel? Yes. Director Gallagher?
Yes.
Director Pimentel?
Yes.
And Tony?
Yes. Okay, so we will move on to item number 4. This is the leadership report. CEO Steve Gray, whenever you're ready. Thank you.
Pull that up. I have 3 topics tonight to go over. First one is the more challenging. It's a bit of a lead in to the finance report, and then have a couple items that are good examples of how the teams here are moving things in the right direction. So I'm going to talk about financial sustainability. I'll talk about clinical services and access, and I've got a patient experience update. So on financial sustainability, I think you've seen this before, but I just wanted to give an update and kind of a pictorial representation. So as you know, district started in 2022 with 8 days of cash on hand, and that has been challenged recently with the delay in approval of the hospital fee program, CLOP 9, which meant a sort of a loss or a delay of $4 million in late last year, plus an additional $10 million plus in the first half of this year. And so we have an accounts payable balance that's ranged between 13 and 16 million in outstanding invoices. I want to just sort of show what that looks like over time. So that kind of squiggly green line is my illustrative sort of representation of what our normal cash balance is. It's kind of always low, but always kind of, relatively steady depending on whether it's a payroll week or we've got a benefits payment that happens monthly, things like that. And the original timeline was QAF 8, and you can see the QAF 8, QAF 9, QAF 10, they all kind of overlap a little bit, and that's kind of been the way it has been throughout the first 8 programs. So QAF 8 dollars really running out at the end of this year, or at the end of 25 and into early 26, and QAF 9 normally would have been approved in the middle of last year, which would have started to bring those dollars in now. We've also got an intergovernmental transfer program that we're newly eligible for as a new healthcare district. That was originally slated to be kind of an April to June timeframe, where we were paying into the state in April and then getting matching funds back in June. Now we have a delay of 3 of those programs. So the quality assurance fee programs have both been delayed, programs 9 and 10. The IGT is delayed. We don't know exactly how much yet. And so we're in this kind of cash gap right now that we're living in, and that we're talking a lot with our leadership team and our staff about. I've also added another one, which is that DHLP2 question mark. There could be another distressed hospital loan program that the state is contemplating that could come either through legislation. There's a bill that's currently working its way through committees that would reinvigorate a new distressed hospital loan program. There's also talk about some of those dollars being put into the budget, which would be available after July 1st. Neither of those paths are finalized yet. Neither of them are certain or confirmed, but there's an understanding that there are other hospitals like ours that are dealing with this cash gap between the hospital fee programs that is challenging us. So we are working really hard to make sure we're not going negative in our cash balance, and that's really what we're working on these days. So with that being really low, sort of funds unlikely to be available before July, how much we're able to pay our suppliers and our service providers is suffering as a result. And so we could have situations where service reductions happen that are outside of our control because we have a vendor or a supplier service provider that has given us the limit on the amount of credit that they're willing to give us and decides that they're not going to provide that particular service anymore. So we're doing everything we can to avoid that, working with those vendors, talking with them all the time. The finance team, the accounts payable team do a lot of that every single day. And just trying to talk and make sure we have open dialogues with those vendors to try to help them understand the cash gap and the things that we're working on to get us there. But some of those might end up being outside of our control. Along with that, clinical leadership is meeting frequently to plan impacts on services. So whether that's planning the ones that are outside our control or actually planning some that may be inside our control to consolidate services and consolidate days. We've done that in acute rehab, in outpatient rehab, things like that. And the care ad hoc committee has been doing work on this, thinking about this. We'll be reporting on this in a little bit as well. I just wanted to sort of give that additional flavor and some of the things that we're making sure that internally we know about. So I'm going to talk about it externally too and show that picture of what that gap looks like. Another item on the financial sustainability pillar that some folks have talked about, but I want to talk a little bit about here and how it might impact us is the Rural Health Transformation Program. So just as a background, California has secured $233.6 million in funds for this program for this year. And they plan to obligate those funds by the end of October. Funds cannot be used for payroll or other cash flow or operating capital needs. So that has been spelled out pretty clearly for us. And instead, they need to be in a hub and spoke regional collaborative network, or with the development of rural workforce or technology and tools. So the sort of leveraging technologies and new technologies. So we could potentially come up with, we have some projects in those areas for sure. And We're also hearing that the state is prioritizing a list of counties that are nowhere near Santa Cruz and Monterey counties this year, right? So we have, this is a 5-year program. We don't know what next year is going to look like, but this year, there's a list of counties that I've seen and we are not on it. Doesn't mean that we're ineligible, doesn't mean we won't get any of these dollars. It just means that if we do, based on the criteria that they've thrown out so far, we would be an exception. So I wanted to, that's not good news, but I wanted to make sure we set some expectations around this, that this is going to be an uphill climb to get any of those dollars here to Watsonville this year. And there's a link there at the bottom if you want to learn. That's where I got this stuff. We can take questions as we go or at the end. We'll go at the end. Good news. Scanners have started to arrive in our building. So this is your Measure N dollars at work, right? So these are starting to arrive, and we have this. The CT scanner has been brought into the building. Ellie's got all the photographic evidence of making sure that they're doing it right. Not scratching it along the way. It's perfect installation earlier this week. So these will start to get installed, all of the things, cabinetry, et cetera, around it over the next few weeks. And then we'll really be at the mercy of the state again in terms of inspection and approval to turn them on and start using them with patients. But it's exciting to start to see them start to come
Get
on.
onto this, get on with it.
Come on and we have also put together, thanks to a number of our clinical leaders, as well as Francis and Sproutling, our folks who are doing some of our marketing work since Nancy's retirement on these referral guides. So we have a referral guide for coastal healthcare and a referral guide, kind of volume 1 for the hospital. These are really outreach tools for our community physicians. We'll be bringing these to the community physician offices. The first one for the hospital includes labor and delivery and radiology and surgical services. And so we're letting our doctors know, reminding them we're here. If they've been referring to other surgical centers, if they've been referring to other radiology centers, if they've been referring to other surgical or clinical specialists, we want them to know that we're here. We want them to know what services we're now providing, what new services are coming online with the Measure N dollars, et cetera, and how to refer patients to us and to our services. So trying to make this really easy for them, both in paper hard copy as well as electronically, so that as it gets updated, we can bring them new copies of things. So access those online. So excited about this really long overdue work to reach out to our docs and let them know how to get their patients to us. Patient experience. I'm going to share inpatient. So all of these are for our inpatient patient experience. And this is just taken straight off the Press Ganey dashboard. So you go on the Press Ganey site and there's a snapshot of how your hospital overall is doing. And I was kind of blown away by this graph, which is from 2022 to 2026. 2026 is through as of yesterday when I pulled these data, about 75 or 80 surveys that have come in so far for patients who have been here in 2026. We tend to get about 300 or 400 a year for our inpatients on the survey. We're working on, as we've talked about before, working on increasing the survey response rate. But in the meantime, the percentile rank for the hospital has gone up every single year since the district was here. So that's something to be really proud of. Currently the 67th percentile. That's nationally for all hospitals across the country, 693 of them that use Press Ganey. This is the distribution of responses. See 72% of all responses for all the questions for all the surveys for 2026 year to date. 72% are very good, 20% are good, and then 7.8% fair, just 0.2% poor, and 0.0% very poor. So that's the distribution of scores for the surveys that have come in so far for 2026. And then we can also break that down by specialty within the inpatient survey. And so this gives a really interesting view because this is, so for telemetry, the 82nd percentile, that's compared to all other telemetry units in the country, in the Press Ganey database. And obstetrics is 74th percentile compared to other obstetrics, because it's, you don't really want to compare obstetrics to everybody else because, and Kim's here, but patients in labor and delivery tend to be happier than patients who are here because they don't want to be because they're sick, right? So comparing obstetrics to everybody else would be making them look, be just not apples to apples, right? So at the 74th percentile compared to all obstetrics in the country is really good, and 69th for med-surg also really, really excellent. So I'm really impressed and humbled by the fact that these our frontline staff and our leaders and our physicians are doing this amazing work, despite all of the junk that's swirling around us financially and supplies wise and everything else. So I can go back to any of that if y'all have questions about any of those items. Those are my updates for today on 3 of our key strategic priority pillars.
Any questions for Steve on this report before I go on the comment that you want to go on?
We'll go back to the very first one, crisis in the moment for our cash position. Maybe it's the second slide when it is. Third slide, sorry.
That one?
The next one when it got worse.
This one?
Yeah. So the green line is that we're saying illustrative, just
Yeah.
understand the data. At some point in time, it's actual numbers and then it turns into projection.
No, I just drew it by hand.
Oh,
for this slide.
literally just,
That's why I underlined the little illustrative.
Yeah. gotcha. Yeah, I think frame it in context.
Yeah. I understand.
I mean, we've solved it. Solved is the wrong frame, like I just don't get the right words. I need to go to elected official school for public speaking. We've been able to manage through this moment of CMS, federal government delaying approval of OP9. I didn't hear, I wasn't listening well enough if we have any new insight or updates either from State Department of Health or CMS about OP9 status, or if it's still.
We're still hearing the same thing, which is that it's continuing to move forward and the state is still expecting approval around June. That's what we're still hearing.
And how we've managed cash is a couple things. Historically, we've had some partners such as Central Coast Alliance for Health, who's helped advance funds from CLOP 8 payments. That's incredible. And I understand they're looking at helping us with OP9. I guess the question is, in the crisis of cash, we also borrowed from all of our vendors or physicians. 3 months ago, maybe 2 months ago, we are at a crisis level with what. Maybe I'm getting to a question like trying to understand where I'm seeing a needle going all the way to red. Like where is our crisis level of supply? Trying to quantify, trying to understand the moment of how we believe we've made improvement on getting supplies in place. I believe we've our financial performance that we'll hear about later is turning the corner, even though we're fully recognizing the expensive things. So I'm trying to understand, are we still at the same level of crisis with supply and management that we were a couple months ago? Is it still at that same level of risk and
So as I meet with a number of the leaders in this room, as well as physician leaders, and we've had a lot of work daily task forces around supplies, weekly task forces with physicians, that the supply chain challenges have gotten better compared to where they were a couple of months ago. Doesn't mean that everything's better, doesn't mean that it's always good, and it certainly doesn't mean we're where we want to be. But if you're asking about supplies specifically, we have been able to catch up on some of those payments and get supplies to a more manageable level, than at least than it was during the worst part of it a couple of months ago. But it's certainly not where we want it to be. Yep.
And hearing about IDT, maybe you captured the day job of my life a little bit off guard. Do we have any insight into what's causing an IDT delay? Is it the state funding?
Same thing, CMS.
And the roll through the funding, very much like all time flows through CMS, they're also impacting now, like CSAP. Thank you.
Yeah, and they're not tied to each other, but they are both flowing through CMS in different paths, and so that is, that CMS mush is slowing down.
I'm helpful. Well, we didn't fully grasp the word illustrative in green line there, so thank you.
Any other questions for Steve here before I open up for public comment? I do have a couple of questions, but I'll save them until after public comment. Yeah, I should run a radio show, right? After the break, we'll go back. So, Rosie, is there anyone online wishing to speak on this item, on the leadership report?
No hands on mine.
Okay, anyone in person wishing to speak on this item? Okay, seeing none, I'll close down the public comments, and I have a couple of questions, and then just a general statement, I suppose. But
Rosie, can you leave my slides up? I don't know.
Oh, yeah.
You want me to go to some?
yeah,
Sorry about that. Continue to control her.
Yeah.
Yeah, no problem. The referral guide is really exciting.
Yeah.
So I just want to thank the team who's been able to put that together, and just speaking from my experience of how word travels and how referrals happen in this community in terms of both in the social sector, the social services sector, but also in just general healthcare. I mean, this is what it takes to get referrals, is to be able to show up at a doctor's office and drop this off, and to really turn the tide on that and become a trusted partner again to local doctors' offices and to local medical groups. This is like as grassroots as it gets, and so I just appreciate the team for putting it together. And the cover looks great, and Francis is very talented, so I'm sure that the inside looks great as well.
Yeah.
And also, whenever you have 10, 15 packets, I'd love to drop as well if you need help going to doctors' offices and reintroducing the hospital to the community. I'd love to do that. For the MRI machine, like you said, a few weeks before it's fully installed, and then we're at the mercy of CDPH. I think, what does that approval process look like? And is there any phone calls or emails or any of those things that we can do to get to the front of the line in the meantime?
Yeah, we're already doing those. I don't want to get politicians involved and rock the boat with CDPH, because that sometimes makes things go slower. But our radiology director is here, and our quality director are, having pretty regular conversations with CDPH about letting them know that this is coming, trying to understand. Sometimes you ask two different people at CDPH what the process is, and you get two different answers. So we're trying to make sure that we're understanding that as best as possible, and jumping through whatever hoops they put there for us. So
Understood.
we're making those calls right now. If there's a additional call that needs to be made,
Right,
we can definitely make it. I could call on a lifeline. Phone a friend. Nelly, go ahead.
yeah, Nelly.
So just to kind of give you a little bit of context, as soon as we receive the, fixed delivery dates, I communicated with quality to let them know that this event was coming so that they could put the communications with CDH. We couldn't do it beforehand because the dates were kind of all over the place. And if they were to actually decide to come on time, right, then we don't have anything for them to evaluate. So now that we have them, it gives us a little bit of time to ensure that we get the installation going, start getting our physicist reports and everything that is needed so by the time that they arrive, it's not going to be like a fresh start to an additional waiting time. It's gonna be the process already rolled.
Okay.
So that was something that was decided to do at that time, of recognizing when we were gonna have the meetings. So that was nice to be able to work with quality and get that all really been responsive. So that's awesome.
Great. Happy about that. And then, did we, this wasn't in the slide, but you mentioned Measure N. I think it was in the offices when we were replacing the HVAC and when, I think like a record heat week or something like that, where it's like 90 degrees. How did that project go? And we were also doing some other stuff around our roofs. I'm assuming it went well and we've.
Yeah, it's still going. Air handler unit 3 is the one that is in question there, for part of the administrative building. Robin's maybe really familiar with these.
I am.
And we've got it installed. It's been rebuilt offsite and has come and has been installed. And I heard that they turned it on briefly today. And
Okay.
they're still
Yeah,
working on it.
I realized I never had a chance today to follow up. Yesterday, they were very hopeful that the last bits were done and it would be turned on today. So
Yeah, oh, great.
we're definitely in the home stretch finally.
Bring your foods.
Very appreciate it. Thank you. And then, I think in the last leadership update, you gave an update about the CT scanner as well. Any other additional things happening with the CT scanner in terms of?
So that's the CT scanner.
Oh, I'm
That's the
sorry.
new one.
I thought that was MRI. I'm sorry.
MRI is coming next week.
MRI is coming
Yes,
soon.
so everything is here. Monday, we received the CT scanner. The Tuesday, we received our RF X-ray room. Next week, we received our MRI unit. There is some, with construction, some things
Sure.
always happen, but it will.
Yeah, that's, when we had if you're asking about the mobile MRI unit, we've had that up and running since mid-February.
Okay. Great.
What do you, one other question down the line. Once the new one's installed, there's an upgrade to be done to the old one? Is that already been done?
So the CT scanner is gonna be a second one.
Right.
The repair to the in-house one, happened in, I want to say, August.
Great. Thanks.
Yeah, so we're good with
Yeah.
that.
So
We haven't had any-
Phillips has certified that, and certified the uptime for it now.
Very cool. Thank you. And then I just, I think going, as much as that slide number 3 hurts, I think I'd like to go back there and just.
The gap one?
Yeah, the gap one.
It's an illustrated line, but.
It's an illustrated line, but it's very close to reality. And so I just wanted to take a moment here and just we don't have to go back all the way back into history as to why Clock 9 was delayed or has been delayed for this long, but I just want to, I think there's a great juxtaposition here of all the great work that is happening at the hospital, thanks to our staff who's dedicated, devoted to caring for this community and loves working here. And at the same time, this board is working extremely hard to find ways to fill this gap in this moment. And I know that that's not good enough, is to try and work as hard as we are and to not be able to deliver. And so I just want to take a moment to acknowledge just all the work that's happening from the staff and how challenging it is in the hospital at this moment because of this funding gap. And that, just to acknowledge that the board is working as hard as it can right now to try to solve this gap in all of the different ways that are available to us. And that, I think the five of us are still very bullish in the idea that we can solve this gap and that we will get through this. And it's going to be very difficult, and it is really difficult right now, but there is a horizon there where we feel like we can turn the corner on what has been a very, very challenging, I was going to say 12 months, but really 18 months since the cyber attack, and even a few months before that. So, the slide where we had the 72% of people say very good of their patient experience, I just want to stick on that for a few moments. And again, like I said, it's just a gigantic, the two ends of the spectrum is our staff is really struggling because we are not able to give them the supplies of which that they need to perform on a, I was gonna say consistent basis, but on a 100% basis. And we acknowledge that, and that's extremely challenging, and we hear that as a board, and we're trying to solve for that. And at the same time, our staff continues to show up and continues to provide incredible care for our community. I mean, I see 72% as very good, and then 92% of people saying good or very good. And so, I know that the leapfrog scores and the other, national accreditations and those sorts of stuff, we went from a D to a B, and I hope that whenever the new one comes out, it's an A. That'd be amazing. But, to see this, just brings me a lot of pride to be a part of the hospital and to just continue to fight and to try to solve this really challenging financial time that we're in right now. So just thank you, to staff, leadership, staff, frontline staff, for all that you're doing. And I know that, thank yous only go so far. And as a board, we need to continue to work really hard to solve this really challenging time. So, any other questions or any other comments before we move on to item number 5?
My Catholic upbringing, Catholic upbringing. You said something that was really meaningful to hear, just from a commentary perspective. Thanks and appreciation. The staff of this hospital, physicians in this hospital, our providers in this hospital, our partners in the hospital have helped us get through this moment. There's like this thing there, and you're in the nonprofit world, you hear a lot, like, you're here to, give us your time, give us your talent, or give us your treasure, pick one. And I feel like the staff in this room and the staff at the hospital and the physicians in the hospital have done all three: their time, their credit, their talent. And we wouldn't be able to gap this moment were not for that. It's hard to be an elected official, period. It's hard to be an elected official on this board, period. And it's hard to be an elected official on this board in this moment. This is not at all. We knew this was going to be a hard journey. None of us ever thought this was going to be easy. But the challenges we've had in the last, say, 18 months, it really hit in first quarter 2025. The impacts of all that has just been sad, demoralizing. And the fact that I look around this room and I see a lot of the same faces still fighting. I don't know where you're getting the energy from, and I appreciate that. It's got to be hard and exhausting. But I thank you for that, and I hope everybody who's listening, from the bottom of our hearts to the top of our heads, every brain cell we have, just thank you to everybody who's helped us get through this moment. Well, we're not through it yet, but
We'll get there.
Yeah.
We're working there.
We'll get there.
Okay, any other comments or questions from the board? Okay, seeing none. Thank you, Steve, for the report.
Yes.
Move on to item number 5. It's the Chief Financial Officer Monthly Finance Performance Update.
And I'll just say while she's pulling up the report that it really struck me today, looking at these slides around the patient experience, thinking about slides that Michelle has shared with us on our quality improvements over the 3.5 years that I've been here. It's pretty amazing because it's been all that upward trend. I'm extremely proud of the team here, and our leaders have done a fantastic job. We always just talk about all the cash constraints and where's the next supply dollar coming from, or the next AP call that's coming up, but those slides and what you guys have done is really amazing. Thank you for that. And with that, we will start to talk about March. So we had a strong March. We had about $850,000 favorable income for the month. A couple things that did happen that helped us was that we had some strong volumes, and we got our cyber attack insurance reimbursement finally. And so that was very helpful because that took us, I don't know how many months it's been, close to the 18 months we're talking about here. And it was a lot of back and forth with the insurance company, a lot of strong work to get to the amount that we finally received. We're seeing some very strong expense management, and it's probably important to say here, I may say it a couple times, that you're seeing all the expenses here, even if we're not paying all the vendors or the invoices. We do follow GAAP accounting. We are accruing for every expense that we know about, everything that's been ordered and not yet invoiced. If it's been used, if it's been received, it is recorded in the expenses. So these are not cooked books to look good. These are actual how we are operating. It's much different from last year in that our net operating revenue is much closer to what is budgeted. We were conservative, trying to be very realistic in what we budgeted for revenue. The volumes in some cases are exceeding what we budgeted, in other cases are falling a little bit short, but it's much tighter this year. We're also seeing some strong expense management, and I'll show a few slides that show that in different ways. And we've talked enough about the fact that QAP 9 is not approved yet, so there's nothing about QAP 9 in any of these results from either expected revenue or the expense that we will pay for. So on a year-to-date basis, we are favorable. We have a favorable income of almost $950,000. Again, most of the numbers show that we have favorable variances on many of the expenses, slightly unfavorable, but these particular results are not flexed to the volume. These are just the straight budget versus actual. And so I will show you in a few slides a little bit more of a volume-based analysis. Next slide. Before I get there, just to show you, since the volumes are, show you where they're off or above budget, where for the month we were 26 more admissions than what we had budgeted, had a longer length of stay, so that meant about 5 more patients per day than what we had planned for. Pretty close on deliveries, pretty close on overall surgeries, actually a little more favorable on the outpatient side, but strong on ER visits. We were up to about 96 patients a day in the ER, and really the only place that we're soft is in the non-emergency room outpatient visits, and some of that is by design as we've tried to tighten up the hours that we provide services to meet the demand, but not to have a lot of inefficiencies in the schedule. Next slide. So you can see from a year-to-date basis, most of the areas we are favorable to what we budgeted. Admissions up by 74 and ER visits up by 215. And again, really it's the outpatient non-ER visits. And remember that the first month and a half, we had no MRI there, and we had some softer volumes. Next slide. So it's kind of, useful at times to just look back and say, well, what's different this year in the first quarter versus last year? You know, why are they so different? Certainly, you know, last year we had budgeted for projects that we were planning on doing. And again, we built that budget before we had a cyber attack. So there was things that didn't materialize in the first quarter because we were busy recovering from a cyber attack. There were things that did materialize because other things became a priority or new information came into our hand that we pivoted and went in a different direction. We are seeing that our net revenue is up by about $5 million. Almost $1 million of that is the cyber attack insurance reimbursement. I also looked at how we're doing on collections. We look at accounts that have already gone to a zero balance and said, you know, what percentage of the gross revenue dollars were collected. We've seen improvement looking at the 2 time frames. And when I did some calculations, that was about $1.2 million in improvement. We're also seeing that there's areas where the expenses are less by at 500,000. There's some that are higher, so it's a kind of an offsetting, but the areas where we're down contract labor, we've really reduced the contract labor, partially because we've been able to hire in some of these areas, partially because we have had troubles paying vendors, and vendors have not been able to continue to provide resources. They've either said they needed to pull their resources at the time when the contract, the term of that particular agency resource termed out, they didn't renew it, or we didn't renew it. We've definitely, we put a lot of energy into supplies. There's been a lot of work trying to optimize to make sure that we're spending dollars on supplies, somewhat in a just-in-time moment, but also very kind of carefully aligned with the services we're providing, the surgeries that are coming up, and, you know, just having to be a lot more diligent and not necessarily having a lot of extra stock on the shelves. The other thing we have seen with volumes is in a lot of cases, they're actually lower than they were in the first quarter last year, but they're more proportional inpatient versus outpatient. And so that really does help us. It helps us a lot with efficiency because we have staffing ratios, and it also helps us from the reimbursement side because inpatient does reimburse better than outpatient, especially in the government payers. It's interesting that the payer mix is slightly worse on the inpatient side, and generally the same on the outpatient side. And it's slightly worse, but it does have a little bit of an impact to the calculations. So as we've said, and I just kind of want to point out, it is that it's a good first quarter from a budget to actual. It's a good first quarter to have more net revenue than you have expense. It does not wipe out the cash challenges. And I have a slide a little later on that's going to talk about that cash piece a little bit more. So this is a slide that tries to adjust a little bit for volume so that you can see when we are able to kind of flex the budget to what the volume brings in, how we're doing with our actual expenses. So I'm using case mix adjusted discharges as the way to flex the budget, because this takes into account the acuity of the patients as well as kind of the inpatient outpatient mix that we talked about. You can see we're pretty close. We're within 5% on the net operating revenue, down slightly. And I think you could account for some of that with the softer outpatient volume and a little bit of what I was just talking about on the payer mix being slightly worse on the inpatient side. The fact that we've had strong volumes in most of the areas does mean that your fixed costs are spread over more volume, and so that definitely helps. And when you look at the categories here, some of the ones with the larger favorable variances, such as your pro fees, your utilities, your other, which includes things like the rent. Those are primarily more fixed costs, so spread over more volume makes them favorable. But what you also see is both from a labor perspective and a supplies, which are the most that are volume driven expenses, we are also favorable to the budget. So very strong expense management when you look at it on a more of a volume driven look. Next slide. So run you through some of the graphs I show every month, this one being the inpatient volumes. We had pretty high volume in February, so we did dip in March, even though we exceeded the budget. The patient days, which is the orange line, that just shows you where the length of stay was up to about 3.8 for the month. Next slide. Deliveries, we've kind of been up and down over the last 6-7 months. So a little bit softer than where we were last year, but still kind of within the range that we tend to think of as fairly normal. What was probably lower this month than we've seen for a while was the NICU admissions. We only had 4 in the month of March after having 10 plus for the last 4 months. On the ER visits, I said earlier we had about 96 visits per day. And what the orange is showing you is what percentage of those visits converted to inpatients. And, most of last year we ran in about the 6.5% range. Over the last 3 months, we had seen that creeping up. And then in March, we were down at 6.4%. So we kind of normalized out. But that was 190 admissions that resulted from our ER visits. On the non-ER, we did pick up a little bit. I think the fact that the MRI was up for a full month definitely helped that. Because we really saw it was about the end of September, October timeframe when we lost our MRI machine, and that's where we started to see some of the softening of volume. And it's picking up, but it's not completely there. On the surgical cases, we have the usual suspects of our top volume. We had 45 inpatient surgeries this month, and 42 of them were made up between GI, OBGYN, and general surgery. So that really is the bulk of our volume for inpatient surgeries. On the outpatient side, I tend to look at the top 5. We had 125 in total. 107 of them made the top 5, which is your ENT, ortho, podiatry, general surgery, and OBGYN. And 42% of it, or 52 of the cases, were our general surgery, outpatient general surgery. We also had 24 robot-assisted cases for the month, so that continues to stay pretty steady, and that was one of our higher months with robot-assisted cases. On the payer mix, this is where we did have a drop in our commercial payer mix for the inpatient admissions. Only 12% of our admissions and only 8% of our days. I mentioned earlier that we had a slightly higher length of stay, but only 8% of the days were commercially insured days. So the rest of it was primarily government payers, and primarily 40% was the managed Medi-Cal, and about 32% was your fee-for-service Medicare. On the outpatient side, as I say, much every month, we're very consistent. Payer mix is very consistent. We were 22% commercial. I did take a look, since there wasn't much of a news story to tell, I did take a look and noted that if you look at just emergency room alone and take out the non-emergency, The payer mix, as one would expect, is slightly less favorable. 4.7% was self-pay and 51% was managed Medi-Cal. So that is obviously something that we are continuing to monitor as we think about the impacts of HR 1 and how things change over time. Next slide. So this is my last slide, and I can take some questions after this, but I did want to try to find a way to illustrate the difference between what you're seeing on the income statement and what really happens with cash. And this is only focused on these QAF payments. And what we do when we are accounting for QAF is, first of all, we can only account for approved programs. So this is really just QAF $8. There's no QAF $9 projected or otherwise in here. The blue line across is, even though we don't receive QAF payments in equal amounts, we book a 12th every month of what the net is between what we're going to receive as a payment and what we have paid into to get that payment. So the blue line across the top basically says an annual net benefit of $16.3 million spread evenly. The fact, when we look at it from a cash perspective, is when did we actually take the cash and receive the cash through advances or otherwise? And when are we actually making those payments or projecting to make those payments? And we've negotiated payment plans for the last few years related to the portion that we pay in for QAF. We've also gone to the extreme in the last few months about negotiating how we pay that back. Earlier on, we would do something such as, we'll pay 10% before we get the funds, and we'll pay the other 90% pretty much when we get the funds. Because we've had to take more advances since the cyber attack, we've done further negotiation with the state to say, when I get the funds, not even when I get the funds, when you recognize as the funds have been dispersed, I need a few weeks, a few being like 6 to 8 weeks, to actually pay you back what I owe you. So really what this is showing, or trying to show, is a good portion of QAF, of that $16 million that is recognized as 2026 dollars. There was a good portion of it that or a starting portion of it that was taken in 2025. We took a significant portion in February, and there's just a few residual dollars to come to us in, we got a little bit here just a week ago in April, and there's a little residual for October. But everything else is payments that still need to go out the door. And the ones that I normally would have paid in April, I've deferred through a payment plan to not even start until November. So those two negative lines you see in November and December are payments to cover dollars that I've already received. The end result of that is the net cash that we are actually seeing in 2026 is $2.5 million. So there's that $13 to $14 million difference between what the P&L shows and what the cash actually flowing into the organization. And that very much aligns with what Steve and I have been sharing with you about how this delay in Block 9 has hurt us. So I hope that made some sense, and I'm open now for questions.
I think we'll have some. Any questions for Julie? Coming forward for the public comment? No questions.
I just have one question on that 975,000 cyber attack insurance payment. You talked about going back and forth. Was that based on actual expenditures that the hospital had related to the cyber attack, or was it some other?
It's a combination of expenses that we tracked of what it took to recover from the cyber attack, as well as our projections of what revenue we lost because of the cyber attack. And what it doesn't cover is we had a $250,000 deductible that we had to satisfy before we would get any recovery monies. So we satisfied that, and then we had to negotiate back and forth and somewhat teach insurance adjusters about hospital finances and how it works. And I have a team that did Vanessa, who's my business intelligence manager. She did a ton of work, a lot of back and forth, and really educated them. And I would say that the amount we ended up receiving is more than twice as much as what they initially wanted to give us. So she deserves a lot of credit.
Great.
Thank you. Any other questions for Jill?
I'll see what more comments of them for reflection of the finance committee we gathered. I think that's good.
Okay, understood. I'm wondering, Julia, have about some questions about the inpatient length of stay being so high. I don't know if we have any additional details, and not down to like the actual case by case basis, but just general thoughts and things that you can report back.
3.8 is not necessarily a super high length of stay. It can usually be, one or two patients and have an extended length of stay. Our case mix, the acuity, it was not really that much different than most months. I don't have specifics, but I know, and I see, it's usually, one or two difficult to place patients or
Sure.
somebody who's got an extended illness that can drive that up.
Seeing the head nods, so I'll take that as a yes. And then, I really liked, and this is more, I suppose, just the question, direction, I suppose, but I really like the statistic of the ED mix on the outpatient, that you were able to add later on there at the bottom of the chart. I know that, I feel like a broken record, but I keep coming back to the impacts of the changes from the state legislature, around Medi-Cal, and people being kicked off of Medi-Cal, not being able to, and no longer being able to be eligible for Medi-Cal. I know that there's discussions right now at the state legislature about pausing that for another couple of years. That would be great for us, and I understand that they have a lot of different asks that are before the state legislature this year. But I would like us to keep coming back with that statistic on a monthly basis. I think that's a really great data point for us to understand. And, discussion for down the road, but not in this really tight cash situation. But, that the idea, and I know that there's mixed results on this, but the idea of having an urgent care nearby an ER and being able to move patients, do community-wide education about why, unless there's a very serious, situation, better for you to be at an urgent care than at the emergency room, where that's really difficult for us from a financial standpoint. So great data point. Just thank you for adding that in there. I have some more comments, but I'll stop there.
Yeah, I'll add, I made myself a note to add a slide that looks like this, that is just EDL.
That'd be great. Yeah, fantastic. Thank you. Okay, any other questions before I open up to public comment? Okay. Okay, anyone online wishing to speak on the CFO monthly finance performance update?
It's online.
Okay, anyone in person? Okay, seeing none, I'll close down the public comment, and if there are no other closing comments, then I'll thank Julie for the report.
I was just as a comment, just acknowledge our average daily census at 31.3. That's a good number. I think I appreciate it. So, finance committee member Dr. Gallagher, the rules on the 32 or something according to that, like over time, whenever we've been above 32 in their history of the hospital, things are better. So seeing our average daily census at 31.2 is, I appreciate. That's just a good indicator, and I hope it's odd to say things like that, right? We hope from a revenue standpoint that our average daily census goes up, not from a human standpoint, perhaps. But and with just appreciation and gratitude, the very small finance team, your office, Julie, your team, is being tasked to do a lot of things right now, extraordinary work. In addition to continuous process improvement that you demonstrate and the financial performance and the additional work in your responsiveness to questions. So I want to keep echoing the work at hard. Your team has been responsive to all of our asks. These reports have grown over the year plus. And I just appreciate the work and the transparency which you present. How candid you are in your answers.
Any other comments? Okay, thank you, Julie. Okay, we're gonna now move on to item number 6, and this is a community access to responsible evolution ad hoc committee report out. It says Director Pimentel and Gallagher with Steve Craig. Maybe you guys are ready.
Feel like we're in one of these moments. Pre-coordination. I can
Sure.
lead it off and
I'll fill in.
so our board member Gallagher and I were appointed in February to be on another ad hoc community access to responsible evolution. For our hospital, our primary focus was stabilizing operations and looking into the first 90, 180 days as a short-term financial planning leading to our next 5-year plan. The basis of that is when we were formed as a hospital, took over in September of 2022, we ultimately put together a 5-year plan that had a lot of our milestones and measurements. A lot of that plan is nearing the end of its life cycle. Many of the things we hit on the mark and hit ahead of time, some things, wow, we missed. But it's time to reinvest and do a long-term 5-year plan. That was our hope for 2027, even a couple of years ago. So the care group, the care committee was focused on stabilizing operations largely in response to federal actions and then moving towards the 5-year plan. Very quickly, in seeing the CMS delays and clock 9 go from don't worry, December, don't worry, February, the months are floating in specific days, but then don't worry, April, and now it's don't worry, June, July, that the committee took kind of a scope. You live within the scope of the essence of the committee, so I hope the board's okay with that. We more focused on cash flow financing and looking at bridge loan financing and just making sure we're pursuing all those options, which included participating federal and state representative conversations, local meetings with partners, the alliance, the county, even the county board of supervisors. And that's been a lot of our effort in the last 6 weeks in that space. I think we've definitely hit some huge achievements in getting federal, state, local, and many local partners understanding the turnaround that has happened here, what still has to be done, and the commitment to the next 100 years of this hospital. And so I think we've expanded their universe of cheerleaders who want to be part of our success, who have said, I can get there, but I probably can't get there July or August or September, but we'll try to get there. So so that's been, I just wanted to speak to kind of the scope and a little bit of a pivot that we didn't talk a whole lot about, maybe at all of the last March meetings. We were in the middle of that pivot. Just moving to a scenario looking for some bridge loan financing. We've been putting a lot of effort into that. I'll turn it over to board member Gallagher, who's kind of took the lead on pulling a lot of this together and leading a lot of our meetings with, especially a lot of county board of supervisors and staff.
Sure, thanks, Marcus. In the process, I feel like I got a much better sense of who we are financially, what we've done, et cetera, to be able to portray that to various representatives. The other part of it is that I think, and Marcus, my hearing aids are acting up tonight. We met weekly with Steve and Julie looking at the productivity of various service lines and how to try to make that better. So I think all of that's been really very crucial stuff. If I'm to step back from the details, something I think I've come away from is how dedicated everybody is that I talk to, whether it's county board of supervisors people or medical staff or administration. And I think it's quite remarkable. People are not happy with where things are, but they're committed. Yeah. So those are the thoughts I would add.
This is just an accepted file that we have a 3-page report that just kind of condenses what we just said. Really what the message has been to a lot of our partners is we're still a brand new government entity of a century-old hospital serving the community. And we're going to be here for another century. We've had some big wins in the last 3 or 4 years. In 2025, for a lot of different reasons, HR1 and federal policy change, immigration were the core of creating a lot of friction and issues, and now spinning into bureaucrats and CMS holding on cash payments for all of California. But despite all that, we've had a lot of success, and I think some of our initial response from stakeholders and partners, who of course aren't paying attention to the details like we are at our board meetings. They're not reading our board packets, but their first response is, well, just cut your way out of it. No big deal, just do what we're all doing, and they've really understood the repercussions of closing service lines and what it means for the entire healthcare network, and to kind of reminded them back of why everybody got on board to make sure this hospital was going to be here. And so I don't know that we're hours away from some good news. We've got a lot of good indications. We've moved the needle a lot on a lot of folks who were hesitant to even consider ideas. So I think it's been a lot of work, but I also have seen a lot of eyes open up in progress. And I appreciate, I know staff Steve and Julie, you've been helping us navigate this moment, especially looking at service lines, some of your own conversations that have led to some interim success with Alliance stepping in to look to how they might help us again. We're moving the needle in a lot of places. So it's more, again, an update of the pivot, some of our recent efforts and our continued efforts as we now go in parallel as bridge loan financing and moving into 190, 180 day towards 5 years. Certainly available for questions, and Steve or Julie, if there's something missed.
That was really good. No, I would just say thank you for your support and engagement of the board and the ad hoc committee. We appreciate everybody's, like Director Gallagher said, everybody's commitment.
Okay, any questions from the board for the ad hoc committee on the report or status of anything? I don't think I have a question. It is a final report, and I would like to go out to public comment on it, but so maybe I'll save my comments for you guys till after that. But if there's no questions, I'll go for public comment. Okay. Now opening up the public comment for item number 6 for the CARE ad hoc committee report out. Is there anyone online wishing to speak on item number 6?
No hands online.
Okay, seeing no hands. Anyone in person? Okay, seeing none, I'll close down the public comment. I'll bring it back to the board, and any closing comments from the ad hoc committee before. I'll just say, it's been the theme of our meeting. These are 2 to 3 really crucial months for us, I suppose, as a hospital, and just appreciate, as I voluntold both of you to be on this ad hoc committee 2 months ago, or whatever it was that we put it together. Thank you for your work and your dedication for turning over every rock and leaf and politician available and meeting with them and giving them a reminder, as Mark has said, the exact reason as to why we started this healthcare district and this hospital and saved it in the first place. And as Julie said, the first 3 months have been very kind to us, and we've done a lot of great work in reducing expenses. And at the same time, we know that that's created other challenges, right, with supplies and having to cycle off some of our employees, and want to recognize that as well. We, as Marcus said, we didn't start this healthcare district and save this hospital and bring it back into public ownership to reduce services. And so I'm very happy that as you're going out and speaking to our partners, you're reminding them of that fact that there was this vision back in 2021 when the hospital was facing bankruptcy, that we not only want to save it, but we want to improve it. We want to expand the services here. And so the simple option of just coming in and cutting services is not good enough. It's not good enough for our community. It's not good enough for our staff and for our hospital. And so just again, to the two of you and to Julie and to Steve, for looking for solutions rather than just doing what is on its face very difficult for a board, but is even more difficult for employees and for the community, which would be to just reduce staff and reduce services. And that would, it's not the vision that we had when we started this, and we'll continue to work as hard as we can to make sure that we're following through on that vision that our community had for this hospital and this healthcare district. So just to the two of you, and Steve and Julie, just thank you for, again, turning over every rock and leaf and person that you can find and telling them our story and advocating for us and looking for solutions. Just thank you.
You just want to follow, and I appreciate it.
No.
Just raising my hand. Unfortunately, maybe representative of my day job that I made a reference to earlier, it's hard to get through. If you go back to the slide where we have this gap now where Quad 9 is shut out, IGT is shut out, we've got this period of three to 6 months where cash flow we expected to just be delayed. We've already had to look at right-sizing some operations, and that's going to unfortunately be a continued outcome. If we're not able to deliver and pull together some significant bridge loan financing, which I think we're optimistic we are, and we are facing some really tough choices in this board. I don't want to sugarcoat it. We'll continue to right size where we can administratively and within the hospital operation. But we might be forced to make some tough choices as soon as our next board meeting. Because May is the month. Like May is the problem month for us. May starts Friday. Last time I checked. So we're hoping and expecting some good news. But I don't like that I'm using the word hope. I'd rather be telling you we're on our way. We'll have great news at the next board meeting. But we're not there. So unfortunately, I think we're at a moment in time where there's a probability it's not zero, that we might be talking about more sizable challenges and changes at our next board meeting.
Understood.
I just want to be fair with the moment. We're all trying to avoid that. But for the right thing and the patient safety and staff safety and operational efficiency, that we can't do it all while federal government delays our cash flow.
Any other comments or questions before we move on to item number 7? Okay. Thank you, directors. We'll move on to item number 7. That is the Intel Rad PACS DNA implementation agreement. And this is the recommendation before us is to pass a motion approving signing authority for the Watsonville Community Hospital Chief Executive Officer, Chief Financial Officer, or Executive Delegate for the Intel Rad X VNA implementation agreement, including the software services agreement folder form and related implementation documents to replace the current Philips PACS support path and proceed with implementation. Steve, whenever you're ready.
Yeah, thank you. So, Wattsville Community Hospital Radiology has a PACS system, a PACS, which is Picture Archival Computer System, for storing our radiology images. And so that has been a Philips product for the last number of years. That Philips product and the agreement with Philips expires on June 30th of this year. And so we've been working with a number of different vendors, including Philips and Intelerad, on what the next solution might be, and the clinical team chose Intelerad. And with the Philips agreement expiring on June 30th, and with us getting the final kind of what the agreement was going to look like with Intelerad in kind of late March and kind of figuring that out, I did, as mentioned in the board packet and in the board report, I did sign this agreement with Intelerad on April 14th to make sure that we didn't miss our implementation window for getting it ready by June 30th. And it's a little bit less than 90 days, but Intelerad's pretty sure that they can do that. So, but waiting another 2.5 weeks until today, it was going to be too much. It was going to put that service at risk. So we did do that. And so that's why this is a little bit unusual that I signed it and now I'm asking for permission to sign it. So apologies for that. That's on me. But this system will be an upgrade over what we have. It will provide some great accessibility for our physicians, including a patient portal where the patients can actually go on and access their own archived images. It will also, it eliminates the need for having to burn CDs. So if you've ever needed like your own MRI, or if the doctor that you're going to needs like your MRI, you'd have to go back to the place you got it, they burn you a CD-ROM because that's still a thing. And then you bring that to the office. We can still do that if the patient or the physician's office needs that, but many physicians' offices and surgery centers and things like that are using this system called PowerShare, where we can actually share those images electronically. We can do that through the system. We're able to do that with the system. We've had to just burn a CD. So this will drastically cut down time to be able to need to do that. And it's really vendor neutral, so it can go from our system to other systems really pretty seamlessly. And so there is a $114,000 plus one-time implementation costs. So that's the training as well as really all of the setup and the initial interfaces and so forth to create the system. And then it's $98,295 for the first year, and it goes up by 4% a year after that. It was originally going to go up 5% a year, and they cut that down to 4% for us. So it's a 5-year contract term. So $98,295, 4%, 5 years, over $250. So here we are.
Any questions for Steve, the board,
Or Nelly.
or not? Okay, seeing none, I do have to open up for public comment on this. Would anyone online like to speak on item number 7? Okay, seeing no hands raised, anyone in person? Okay, seeing none, I'll close down the public comment, bring it back to the board for an appropriate motion.
I'll move to pass the motion.
Second.
First we go second, Gallagher.
Yeah, I did. There's another person.
You're echoing tonight. I'll take roll on this item. Director Bally? Yes. Director Creel?
Yeah.
Director Gallagher?
Yes.
Director Pimentel?
Yes.
Chair Davis?
Yes. Okay, we'll move on to item number 8. This is the Da Vinci 9 system, Da Vinci XI system, third lease amendment with Intuitive Surgical Incorporated. Steve, whenever you're ready.
Yeah, so the Da Vinci surgical system, robotic system dates back to really when the district was formed. This is one of the first strategic investments that the district board chose to make, was to invest in a lease for the latest and greatest Da Vinci surgical robot. And we have had that since in place since December of 2022. And as Julie reports, we're starting to see more and more surgical assisted robot assisted surgical cases. Each month, our new general surgeon uses it. We have other surgeons who bring it back into the fold. It's really become the standard of care in a lot of different surgical services. And so the proposal here today is to continue to have that service. And it is this would be the fourth year, extending the contract for leasing both the robot itself and the service. And it's $24,873 per month for the lease and $12,833.33 for the service. And that is actually the same cost that we had last year. So they've been willing to work with us on that.
Nice. Any questions for Steve or the team on this?
What was the price for the service? 800?
$12,833.33 per month.
Curious about the length for 1 year. Is there a value in going longer, or does it make sense to stay on shorter?
Yeah, good question. There was not a opportunity for a discount for a longer service agreement. And there is a new version of the robot. And so if in a year we're in a different place financially, where maybe a slight increase to the service cost would be okay with us, then it might behoove us to be able to do some more clinical things to go to the new robot. It's brand new right now. You also kind of like to wait for other people to try it for a few months before you get the brand new thing. Let them work out the kinks. So we felt like 1 year made sense.
The marketing on the name Da Vinci was brilliant. Anytime I mention it, it just gets people excited. I don't understand why that.
And
Da
they're
Vinci
still,
does that.
and they're still pretty much competitorless.
Yeah. We'll talk about AI, what that new version looks like.
I
Thank
know,
you. I
right?
appreciate the update.
Yeah.
Any other questions before I open up for public comment on this item? Okay, seeing none, I will open up for public comment on item number 8. Anyone online wishing to speak, please raise your hand.
No, hands online.
Okay, anyone in person? Okay, seeing none, I close down the public comment and I'll bring it back for an appropriate motion for the board. Item number 8.
Second, I hear.
On the,
Now you're telepathic. Okay, thank you, Director Friel and Gallagher. I'll take roll on this item. Director Friel?
yes,
Director Gallagher?
Yes.
Director Valley?
yes.
Director Pimentel?
Yes.
And Cindy?
Yes. Okay, so we'll adjourn the meeting of the Watson Community Hospital Board of Directors